Cool. So tendons, speaking of hyperechoic structures, tendons are hyperechoic. They're compact, fibrillar, and in short axis, they have this bristle-like pattern. Long axis have this fibrillar pattern. This is an Achilles tendon. Muscles tend to be more isoechoic to hypoechoic. These bright lines you see here, these are striations. These are part of these tiny little tendon slips that will eventually become the bigger tendon slip. This is of a gastroc. And in short axis, you have this quote-unquote starry night appearance. The ligaments are also hypoechoic, especially if they're strained and filled with edema, then they tend to be even more thickened and hypoechoic. This is filled with edema. This is an ATFL. And nerves have this honeycomb-like appearance in short axis. They're probably one of the most difficult structures to view on ultrasound. In long axis, they have this tram track-like appearance. It's brighter on the top and the bottom. That's part of the epineurium that you can see. When we read ultrasound, we start with our bony landmarks and work our way up. In this case, this is the humeral head covered with hyaline cartilage, hyperechoic, rotator cuff on top of that, with a tiny little slip of physiologic fluid within our subacromial subdeltoid bursa. On top of that is peribursal fat, which is hyperechoic. Then we have this isoechoic striations of the deltoid, subcutaneous fat, and skin at the very top. Cysts tend to be have this through effect, which is a artifact of ultrasound. Since sound travels faster through fluid, you get a brighter or a more hyperechoic signal on the bottom of cysts. So you can tell that this is filled with fluid, in this case, simple fluid, because it's anechoic, because it's showing brighter underneath, as is here. This is not a mass, this is more hemorrhagic cyst. Knee effusion, we're going to talk about this in a little bit. Here's our patella, shadowing underneath the patella, because sound wave's not going to travel underneath that cortex. You have our quadriceps tendon over here, suprapatellar fat pad, prefemoral fat pad, and this is the suprapatellar joint space where we can see a little bit of effusion starting to happen with our simple joint fluid. Femur down here. Limitations, it's highly operator dependent. So if you guys want to be good at this, it takes a lot of practice. And now is the best day to start is today. If you can get your hands on an ultrasound machine, even if you can't, start reading about it and read on anatomy, because anatomy is one of those rate limiting factors. You got to know a lot of anatomy to be a radiologist and to use ultrasound effectively. Depth versus resolution tends to be a limitation as well. It's good for superficial structures, but not so much for deep if you're trying to go for a diagnostic or MSK standpoint. And there's artifacts galore. We talked about through effect, but the last one I want you to make sure you know is anisotropy. If your probe is not completely perpendicular with a linear structure, all the sound waves that are emitted by the transducer are not going to be received by the transducer. If you're off by even 3 to 8 degrees, you're going to lose some of that signal. Therefore, the sound waves that go back, bounce off aren't going to come back to the receiver. So it's going to think that it's darker or hypoechoic, even anechoic. So it might think that tendon's not there or even damaged. This is called anisotropy. And also, you got to be careful as tendons start to curve in, especially as they enthese on bone. A lot of curved things. You got to make sure you're always striving to make the best image, always striving to make the structure in question look as good as possible. Otherwise, you're shortchanging yourself and kind of selling out for pathology. These are some fibularis longus and brevis tendons wrapping around the talus, or lateral malleolus, excuse me. And you can see as they start to curve, they become darker, more hypoechoic until they become anechoic. It's not that these tendons aren't here. It's just that these sound waves are bouncing off and not coming back. Cool. Really beneficial and cheap. Moving on. Tendinosis, when tendons become thickened, heterogeneous, and hypoechoic. It's more fiber disorganization and micro tears turn to macro tears, and then this kind of tendon is the one that ruptures. So knee, we're going to look at anterior, medial, lateral, and posterior views. The anterior view we looked at last time, the suprapatellar evaluation, as is the infrapatellar, looking at the quadriceps tendon and looking for joint effusion like we kind of saw just before. Infrapatellar looking at the patellar tendon, Hoffa's fat pad. Sunrise view gives you a little sneak peek at the cartilage, even though ultrasound's not great for cartilage. If somebody has a osteochondral defect, you might be able to pick that up. And then we're going to finish looking at medial lateral view and posterior view. So remember, we have our MCL, LCL, and the meniscus in between each one. You're only going to see a tip of the iceberg of each of these menisci. Ultrasound is not good at looking at the entirety of the meniscus, nor the ACL and PCL, due to how deep they are within the joint itself. For those structures, MRI is going to be superior to ultrasound. So brief review of suprapatellar view. Here's our patella. Once again, can't see underneath it. Here's our femur. Suprapatellar fat pad, prefemoral fat pad, and you can see the joint recess here and the beginning of the suprapatellar joint recess over here. This is borderline effusion going on. You can see it start sneaking up. Here's another, this is a much larger effusion. And here you can see, as you're moving the transducer proximally, you can see the quadriceps tendon branch out into 4 different tendons: vastus intermedius, vastus medialis, lateralis, and rectus femoris. These 4 tendons spur from the quadriceps tendon. And here's the femur. Infrapatellar evaluation, here's the patella. Here's the patellar tendon coming down, attaching at the tibia. There's not a lot of irregularity here, so this person probably doesn't have any Osgood-Schlatter's disease. Here's our Hoffa's fat pad. Here's an example of prepatellar bursitis. So once again, here's our patella. And when you start seeing a lot of this tissue over top the patella, as you're going to see in our demonstration in just a moment, there should not be a lot of tissue over here. This is all subcutaneous edema. This is all a lot of like hemorrhage or old hemorrhage within the, this looks like a chronic prepatellar bursitis. This is the bursa within here. A lot of schmutz in there, very isoechoic. This is a simple effusion or bursal effusion in short axis. Actually, this is long axis. Here's the patella, here's our patellar tendon, and here's all that fluid within the bursa. So prepatellar bursitis is also called housemaid's knee. And this is kind of what I was talking about with Osgood-Schlatter's disease. You can have a lot of irregularity. This is not a lot, but this is just some of the tibial tuberosity. And you can get deep infrapatellar bursal effusion in acute instances and probably some cartilage thickening. All right, let's take a quick look at those before we move on to medial and lateral knee. And actually, I'm going to do all of this in one shot. Medial meniscus. Remember, this is always bigger than you think it is. It's always thicker than you think it is. Starts at the medial femoral condyle, comes down. It's going to wrap around all the way to the pes anserine in front. It actually goes quite a ways down. And it has superior and deep components to it, the deep attached to the meniscus. That's above your pay grade right now, but there's a lot more ligaments than we teach you, just so you know. Medial knee, you're going to see the femur. You're going to see this big triangle of the medial meniscus, and you're going to see the tibia as it continues down. It's hard to get all of the medial meniscus in a single view, but this is all you see of the medial meniscus. You're not going to see anything else in there, which is why ultrasound's not a good evaluation of that. Here's a fusion right over top. This is some where the medial meniscus is attaching to the pes anserinus. This is a pes anserine bursitis. In lateral knee, you have the femoral condyle, lateral femoral condyle coming down and attaching at the very tip of the fibular head. It's a much thinner, much weaker tendon than the medial meniscus, but it certainly serves its purpose. The popliteus tendon is actually traveling underneath this tendon, and you can see, you identify its location by the popliteal groove, which I'll show you. Here's it attaching to the femur, comes all the way around and attaches to the fibula. A little bit of lateral meniscus. Here's this groove we're talking about for the popliteal tendon, right in here. Because it's curving, it's difficult to see. It's very subject to anisotropy. Here it is again. Here's that groove, the popliteus tendon we're talking about. lateral meniscus, a little bit of tearing going on. And here's this very ugly extruded medial meniscus. When the more the lateral meniscus, the more it extrudes, the more damage is going on. It's probably not a healthy looking meniscus on the inside either. You can also see the IT band on the outside. And we'll get to posterolateral in a second. So let me leave it here and I'll show you those structures real fast. All right, I'm going to switch over. Yeah, I'm going to switch here too. Your choice. Good knee or bad knee? Bad knee. Let's do bad knee. We'll see how bad it is. Let's stop sharing here. I'm going to switch to wake this up. Let me know if you can see that. Yep. Good. All right. So let's take a look at the camera over here first. So when we're doing our evaluation here, it's important for you guys to know exactly where I'm putting the probe. So when we're checking our landmarks, let's zoom in. You want the patient to roll up their pant leg as far as they can if they have a pant leg. And when we're evaluating, so once again, looking at our transducer here, you're going to have a side that has a little nub on it and a side that doesn't. This is usually going to either be on the medial side of things or the superior side of things. So when we're evaluating the quadriceps tendon in that anterior view, it's going to be, this is long axis, this is short axis, same thing. We're going to come down over the patella. Infrapatellar is going to be over here. Then when we're looking at the medial knee, we're going to be looking right here at the joint line. And you can, of course, palpate using your hands all the way down to find where that joint line is. And you're just going to place the probe right along that joint line. So you're seeing the top of the meniscus crossing over, and it's going to come around to the pes anserinus. And for the lateral knee, you're going to go this way. You can have your patient in the supine position for all of this. If you're really trying to focus on an area, though, I recommend that you either fit the patient lateral recumbent, and either way, if you're going to do looking at either side of the knee, or prone when we're going to do our posterior evaluation. But that's just for you guys to know. So moving on, you also want it at like 30 degrees flexion if you can. So I'm going to get some ultrasound jelly. Here we go. Let's increase the depth of this just a tad. There we go. Over here, we're going to have the patella, and you can tell by the shadowing, you can tell by the quadriceps tendon, the femur is down here. We can penetrate the view all the way down. This is prefemoral fat pad. This is suprapatellar fat pad, and you can see the creeping of that suprapatellar recess already. We look at our quadriceps tendon and we say to ourselves, you know, that's kind of thickened. It's not the brightest tendon, but we're also on a curve. I can push the probe down to try and make it more perpendicular to the image, or I can just simply tell the patient, okay, can you contract your quad? And I do that, and you see it really straightens out, much, much brighter, much less worrisome for anisotropy or tendinopathy. Relax. And I can scan up over top the knee. You see how little tissue's there? You can see the fascial continuation going across of the continuity of fibers between the quadriceps tendon and eventually going to the patellar tendon. So moving inferiorly over top the patella until we get to patellar tendon, with on this side, you see the tibia on the very right side of the screen. Can you contract one more time? And you see, it's not quite as big as the quadriceps tendon. It's not supposed to be. Going straight across this way. Up over top, moving superiorly over top the patella again, and this way to the quadriceps. We can always turn it in short axis, this way. So I'll start on the patella and move superiorly, and look at the fibers of the quadriceps tendon. So here's our quad tendon. It's patella, and you see the quad tendons inserting, starting to come off. This is all quad tendon, quad tendon, quad tendon. You're going to start to see the different muscles of the quad peel off of it. On top, on either side, and underneath eventually, if we keep traveling north. So that's our quad tendon in this evaluation. Going back to long axis, let's go down the patella to patellar tendon. Look at patellar tendon in short axis, and there's our patellar tendon. You can see it's not quite as big as our quadriceps tendon. Did you have some work done here or no? You did, right? Yeah. You had peeled off the side, right? You had ACL repair? Yeah. So you can see a little bit of darkness on this side of the tendon because in Danny over here, she had part of her patellar tendon harvested for ACL reconstruction. So she has a little, you can see just a little bit on the side. It's not quite as bright as the rest. And you're like, well, I don't think I could have told that. You know, that's okay. When you've seen 100 patellas, and then you'll have a better idea. When you've seen 1,000, that's even better. When you've seen 10,000, that's great.
You see the divot where they harvested it. Yeah, you could feel it.
I bet you can feel it. So this is all patellar tendon. This is where a lot of it was harvested,
Yeah.
right
I
there.
think they cut the middle and so did.
It's the middle. It's, yeah, you can see this is the
Yeah.
whole thing, and this is where it's harvested. Right, good. It's much flatter tendon. Yeah, you can see where,
Right
yeah,
there.
yeah.
That's
So
what it
here,
was.
moving inferiorly, this is where it's supposed to insert on the tibia. You see this divot right here? That's not supposed to be there. That's also part of the procedure where they harvested some of the bone. You see that? That's what it's supposed to look like, not this big divot. You see that?
Yeah.
All right, good.
I'm watching it on this.
All right, good. Even though you have first person view. So that's anterior evaluation. Let's move to our medial. I'm going to try and find that joint line. Let's get some more gel. So this is all femur, travel south, inferior, inferior, inferior. And here we go, there's our joint line right at that arrow right here. Now, if I move a little bit more posteriorly, I should be able to find that MCL a little bit more clearly. Here we go. It's this band coming down right over top. So where this arrow is, you can see, you see the break in the bone, that's where that joint space is. Just making sure. Yeah. Down to here. So the arrow is like right over top that medial meniscus. And the white fibers going up over top are MCL. Coming down, that's a better picture, this way. Coming over, coming over, coming over, and eventually attaching over here at the pes anserine bursa. You can see the difference. You see that line between the, I'm going to put the arrow right on it. That arrow, seeing that black line going straight across, that's the difference between where the tendons that attach to the pes anserine, the Sargent T, remember?
Mm-hmm.
Semi, do you remember what they stand for?
Yes.
Semitendinosus, gracilis,
and
sartorius.
sartorius, yeah.
Yes. So those guys are the ones that attach. and underneath is our MCL. When you see bursitis, you see it either in between or on top of that. But anyway, yours looks good, going up over top. Yeah, good tendon. Your meniscus is not extruded, thank goodness. And if I wanted to do dynamic testing, I can, while holding on, if I'm very clever, I can try and do a valgus stress test to see if I can provoke any movement here. And she's not moving at all. She's not budging. Just a little bit, but that's, you see that moving? Yeah, that's not moving at all. So that's if I found some laxity on exam, I could throw the probe on and see what's moving exactly. Moving to lateral exam, I find the fibular head palpating. I place the probe on. Over here, it's my fibular head. Let me move this. Fibular head over here, and this is going to be a little bit of tibia, joint space right where that arrow is, coming up over top of the femur. Make it, fibers are going to be the, let's get these a little bit better. This is the femoral condyle. Here's that groove of the popliteus tendon that I'm talking about, right where that arrow is right now. It's hard to point and do this. This is the groove of the popliteus tendon over top of the femur. This is the start of the LCL coming across. If I turn the probe, you might be able to see the popliteus tendon a little bit better, but it's really subject to anisotropy. There it is right there. So groove of popliteus tendon. Now I know I can follow this across until I reach fibular head over here. And that's LCO. If I wanted, so here's our joint space right here. Once again, you can't see a lot of meniscus, but this should be a triangle over here. I can try and do LCL or varus stress test, try and provoke this, try and stretch it out. It's not moving much. Not moving much at all. Good. All right. If you want to look at IT band, it's going to be a little tough to see with where your pants are. We'll skip that one. It's not, yeah, everybody can find your IT band. It's not hard to find. All right, let's quickly skip, or not skip, but move on. Whoa, stop share. Okay. Looking at, if you just did lateral knee, posterolateral knee. Everybody wants to know fibular head. So as DOs or DOs to be, the fibular head holds a little bit more extra significance to us, especially osteopathically, where we can talk about common perineal nerve entrapment. Remember, the perineal nerve is going to, common perineal nerve is one of the two branches of the sciatic nerve, the tibial being the other. It's going to come around and wrap over the, around the fibular head before it splits into superficial and deep perineal nerves. Now, they're now called fibular nerves, just in case you guys know. So sometimes as it wraps around, it can get stuck just really on the fibula from the fibular motion, the fibular tibial motion, or it can get trapped through something called the fibular tunnel. This is the fibular nerve over here. This is the fibular nerve over here. Perineal nerve, they're the same thing. Another important thing to know is the popliteal fossa. Everybody wants to know about Baker cysts. What is the definition of a Baker cyst? It is not just some cyst on the back of your knee. It actually has a specific definition. And if you guys are going for PM&R, you will probably be pimped on this at some point. So that's one of the criteria. So what you need to have for a true Baker's cyst. A Baker's cyst is actually a continuation or it's a hypertrophy of the bursa that goes between the semimembranosus tendon and the medial head of the gastroc. As it gets bigger and bigger due to increased friction or really anything that would make it bigger, it will have it might develop a communicating neck with the actual joint space itself. So by definition, a Baker's cyst is a cyst that's between the medial head of the gastroc and the semimembranosus tendons that communicates with the joint itself. How I remember this is like bakers make yummy stuff. Like, so it's like medial head of the gastroc and semimembranosus. Those is two M's. That's how I remember which ones it is. And it communicates right there. So it needs to have that neck. And here's a good example. This is what it should look like in long axis. As you can see, you see the semimembranosus tendon coming down to attach on the tibia. And here's the medial head of the gastroc. This is the muscle as it turns to tendon. It's going to attach on the femur. You're going to see something pop out in between. That's a very pretty looking one, like a lollipop. They don't all look that pretty, but you'll see the neck. You'll see the neck, and that will be a Baker's cyst. A normal one's like 3 centimeters. They're pretty big, but draining them isn't always what you do because sometimes they just come right back. Anyway, we're going to skip that one. So how you evaluate the posterior fossa of the knee. Have your patient, this is the last thing I'm going to show you before we move on to whichever side's easier for you. What did I do? I did this one. I'll take that. Thank you. Okay, so now I'm having the patient lie prone. I am going to have the probe placed so the left side of the screen is oriented medially, and this is in short axis. I'm going to increase the depth over here. I'm going to start inferior, move superior, and you can see on the left side of the screen, the right side of the screen, those are our 2 femoral condyles. Do you see that? 1 with the hyaline cartilage there, 2. In between, you'll see, depending on where you are, this is your tibial nerve. I'm going to put it right on the, that arrow is pointing right to the tibial nerve, right there. Let's get a new arrow, right here, tibial nerve. If you followed this up, you would find the sciatic nerve. If you're looking for a tibial artery, if you're like, I wonder if I'm pushing too hard, if it's around here. Well, yeah, it's going to be right next to the tibial nerve. Let's get rid of this. You can kind of see it pumping away, but due to depth, it can be difficult to see. But there's our tibial nerve right there. So I'm going to move medially over here. Here, down here, is going to be our medial head of the gastroc. This is all medial head, as it's going to slowly become tendon. And this is the semimembranosus coming down. So it's actually, we're going to look for it in between these 2 structures, which I'm not seeing it here. These tendons are very subject to anisotropy. So really be diligent, because if you're like this, you might be like, oh my gosh, that's a Baker's cyst right there. But if you tilt your probe, like, nope, those are 2 very healthy tendons right there, 1 and 2. So you have to be very diligent with making sure you create a good image. If I transition this to long axis, with the left side of the screen being superior, there's our medial femoral condyle coming down. This large structure is medial head of the gastroc going superiorly. If I alter our probe, you can see it coming up. Let me see if I can get some of the semimembranosus tendon. Here we go, semimembranosus tendon coming down this way. Straight down this way. And joint space is going to be deep to that. So you're going to look at this crisscross point over here to see if there is a Baker's cyst, which luckily there is not over here. Back to short axis. There you go. And then posterolateral evaluation, looking at the fibular head. It's difficult to find that common peroneal nerve, but you can find it. For her, it's right here. It's this thing. It wraps, or it spirals around pretty quickly. So as I move superior, inferior, it's gonna, you really have to tilt the probe to get a good picture of it. Here it is. And you can see it, just I move a little bit superiorly, it's gonna be wrapping right around that head, wrapping right here. Anyway, so let's move on to some cases. I picked these cases both because they helped me to learn a lot, and there's things that I saw in my practice. I think most of them are. One might not be, if I remember correctly. But does anybody have any questions or want to see anything else before I move on? Yeah, throw it in the chat if you need. Otherwise, whoops. Let me share screen. Case presentations, here we go. So I got a couple of them. Yeah, by a couple, I mean like probably 4 or 5. Anyway, case number 1. Yes, okay. Left shoulder pain, 54-year-old guy without any significant past medical history, doesn't really go to the doctor. So this guy is a legit juggler. He travels around the country. He's part of a circus. And he, in the winter months, he fell sideways onto an outstretched hand, and he felt a big pop. He started experiencing deep anterior shoulder pain and chest pain. It was sharp. Sometimes it was achy, but it was very deep. He denied any paresthesias, weakness, or radiation of pain, and he admits a night pain when sleeping on it. Nothing really helps, though he wasn't taking any over-the-counter meds, anything like that. So here is like an example of what you might do for shoulder exam. You do your observation, your active and passive range of motion, palpation, and then your special tests like your neuro exam. Shoulder has a lot of special tests. None of them have particularly high sensitivity or specificity. That's why we do a lot of them, just to make sure the more that you have, hopefully the more accurate your test is. So basically, the significant findings of this guy's test, he had trouble with internal rotation or a liftoff test, which is like where you put the hand on the back, you try and push off. It's a measure of your strength with internal rotation. His biceps was a little weak. And he had some pain with using the biceps. Other than that, he just had a lot of tenderness over the anterior shoulder, right in like the long head of the biceps groove. He was afraid that he had torn his biceps, actually. So when I did his shoulder exam, I looked at the subscap. This is, remember, you start in the anterior view, and you have the long head of the biceps tendon, then you have the person externally rotate your arm, and you see what the subscap is coming around. This is what it's supposed to look like. This is what it looked like. Here's his long head of the biceps tendon. Here's some of it too. Actually, this is long head of the biceps tendon. He completely pulled off the transverse humeral ligament off of top. Here's the inner tubercular groove. This is where the tendon's supposed to be. And it's pieces of it's left. So this was called he had differential diagnosis, is a full thickness subscapularis tear, which is very uncommon, but it does happen. Yeah, so it's very uncommon. Why did I pick this case? Because I wanted to teach you guys something important about the attachment of the subscap. Remember, it attaches on the lesser tuberosity, right? It actually has this comma shape on the, like, you got to bear with me here. Think of it as a comma shape where most of the tendon attaches at the circular part of the comma. By far, majority of it attaches at the F1, F2 area. And then the F3, F4 area tends to be less tendinous and more just muscular attachment right onto the bone. So he had full thickness tear of the F1 and F2 attachment, but that there's a difference between a full thickness tendon tear and a complete tendon tear. And here's the difference. This one, F1 and F2 region was full thickness torn right off the bone. However, it wasn't a complete subscap tear because he still had fibers down here that were attached. He could still perform internal rotation. He still had strength. So you can have full thickness without complete. So if you're giving somebody a diagnosis, oh, I had a complete tear or I had a full thickness tear, you guys are becoming physicians. You should start to better be able to distinguish what the difference is. You can have full thickness complete, but you can have full thickness incomplete tears. In this case, it was a full thickness incomplete subscapularis tear. So this guy, we drained a lot of this hemorrhage, though we couldn't drain all of it. This is actually with half of it drained. He had a lot. So we ended up leaving some of it in there. We called it free PRP, and he actually did really well. He had some instability of the long head of the biceps tendon after that, which that subluxing out of the intertubercular groove gave him more pain than the subscap, but he could still juggle. He still had plenty of collateral tendon remaining. So I thought that was a very interesting case. Moving on to the second case. By the way, if you have any questions about those cases, throw them in the chat. Case number 2, 34-year-old female, 2 kids, complaining of left shoulder pain. Pain's going on for years and getting worse. She's an athlete and a weightlifter and now a mom. Pain is sharp and severe with range of motion in almost all planes, especially abduction. She had a difficult time ratcheting up arm, but can get full range, almost clunks underneath the acromion partway up. Denies any paresthesias, weakness to pain, and admits to night pain and sleeps in a sling. She's in so much pain. So she had her impingement tests were positive, including Hawkins, Neers. She had negative O'Brien and bicep load test. AC joint cross-arm test was positive. And she had a lot of tenderness on the greater tuberosity, but she had full range of motion. What was most peculiar was while you palpated her AC joint and her greater tuberosity, you could feel a clunk actually happen as she was trying to get full abduction. And then once she got that clunk, she could go the rest of the way further. So she came in to me with an X-ray, and you saw this. But I also scanned her. And here's her supraspinatus tendon. It's hypoechoic, it's thickened, and you see this nice, bright hyperechoic line, and this guy right inside the tendon. So does anybody know what that is? So this is actually something called an enthesophyte. It's a bone spur in layman's terms. This, it's a sign of remote trauma to a tendon. Like anything else, after a remote trauma, you can have calcifications develop. So this was the body's attempt to try and heal a prior tear, and it did its best, and it was left with some calcifications. And these are painful. These needles sticking into the tendons, you can see how it can quickly become an impingement underneath the acromion, because this isn't just some flexible tendon. This is all out freaking needle of calcium. So what happens here, so we call this calcific tendinosis. You'll see this in basically 3 stages. Precalcific stage is usually asymptomatic. As it starts to calcify, it goes through 3 substages. The last of which, the resorptive phase, is the most painful. But the formative phase, this is as it's starting to get harder. You'll see it like a real true calcium. You see it's having there's some shadowing underneath because it's actually like pretty hard. Then it starts to go through eventually the resorptive phase where it was hard, and actually at this point it has more of a like really dense, like frozen toothpaste kind of consistency to it, and eventually it become very hard. But what you can do with these things, this is an example of very bad calcific tendinosis. This is not in a needle pattern. This is somebody who really shredded their tendon and didn't heal very well. So this is evidence of prior trauma. And usually underlying tears, bad tears. This is another example of an enthesophyte coming this way, right here. And this whole thing is calcium. Once again, right here. So what you can do with ultrasound, under ultrasound guidance, you can actually go with a needle, and depending on what stage of this is, you can break it up and inject saline with a little bit of mixture of lidocaine. You inject it in and you suck it out. You inject it in, suck it out, inject it in, suck it out. And as you do that over and over and over again, as you're breaking up the calcium, you'll notice your syringe went from having clear fluid in it to having milky white fluid in it. So then you replace the syringe, you get a new one with the same fluid, and you keep doing that, and slowly you start to slowly dissolve all this calcium away. Not depending on what stage it is, it depends on how much calcium you actually get out. But sometimes I'll go through 6, 8, I once went through 10 different syringes pulling this stuff out. And you just really, this is called barbotage, B-A-R-B-O-T-A-G-E, barbotage, or barbotage, I forget what the spelling. But that's something you can do with ultrasound, and you can really help people out. And that's one way of dissolving their tendons. Yes.
Is there a specific point in that healing process where it's like maximum?
Is there a specific point in their healing process that's like the golden place to get it? Well, usually either midway, not when it just started happening, but midway here, you can kind of break stuff up. Once it's late stages is when you usually see it. It's much more difficult to break this up because it's very, very hard, but you can. It's also painful, but you can. You give them, you're very liberal with that lidocaine. This is an example of a lot of Doppler activity, power Doppler activity showing vasculature, increased vasculature to the area, meaning this is more acute. Anyway, next case. So we have osteopathic considerations for these. Spencer technique is great for these things, but I will Spencer people after the procedure. Why? Because their shoulder's full of lidocaine now, and now I can take that time to kind of mechanically further break up any calcium that's left in there. But Spencer's great for this, totally. Is this all right? This showed up right over here. Look on my screen. Do you see this? Over. Oh, no, I'm looking at this. That's okay.
That's fine.
All right, good. Case 3. Okay, cool. Case 3 is a classic case. Now we're moving to knee. Woman comes in, 65-year-old woman, just went to Portugal, had a great time. She walked like 10, sometimes 12 miles a day. She was having a blast. She normally suffers from some knee pain, but it's only every once in a while. She comes back to me and she's like, my knee feels a little stiff. I have a hard time flexing it all the way. It seems a little swollen to me. And it's most painful when I try and bend it all the way. Otherwise, it's just a little stiff and hurts a little bit. So you go through all your different tests, you do your ligament, so range of motion, you know, she has a little bit limited range of motion and active passive, only in flexion, she has full extension. Palpation, she's a little tender, and she has some of positive fluid wave over here, neuro exams normal. You notice also patellar grind test hurts, and patellar tracking's fine. And here's what you see under ultrasound. Here's what you should see. Remember, this is the anterior suprapatellar view. Here's our tibia, patella. Here's our quadriceps tendon, suprapatellar fat pad, infrapatellar fat pad. There's the kind of the suprapatellar space where it should be. Here's what hers look like. So this is left versus right. Hers, you got a lot of effusion peeking through here. So once you see this kind of effusion, you'll also see the effusion start to look on the sides. It's called saddle bagging. It will start to peek out on either side of the medial and lateral knee as well, especially superiorly. So what you actually do with the needle in this view, you actually poke through in short axis, come through, and you can drain the knee from here. I think we drained 20 cc's of fluid from her, which isn't a ton, and then put a little bit of steroid in there just to make her feel better. And so the reason it felt tight and stiff is because she had a joint effusion. So when you try and fully flex the knee and patients have pain, that's usually because of a joint effusion. Now let's take another question. Where did this joint effusion come from? Well, when you see joint effusions in the absence of any rheumatologic disease and really low suspicion of any infectious disease, 9 times out of 10, it's an exacerbation of osteoarthritis. Like one of my attendings used to say, the differential on this one is number 1, osteoarthritis, number 2, osteoarthritis, number 3, osteoarthritis. So don't forget about the zebras, but common things are common. This is just an exacerbation of a OA. Ignore that. That was misplaced. Okay. So osteopathic considerations, circulatory fluid model would be a really good idea, doing some popliteal release, myofascial release, working on the pelvic diaphragm, respiratory diaphragm, of course, first and foremost, your thoracic outlet to try and decrease the amount of edema by increasing lymphatic flow. You can throw in some pedal pump as long as their calf isn't too tight, and you'll do a great job. Also in this case, sometimes you'll see a Baker cyst, especially if it's truly communicating with the joint, you'll see it back there. So don't think that, oh, I found a Baker cyst, I should drain it. Well, it might be because the rest of the joint has an effusion too. So if you drain this part of the joint and milk out the Baker cyst, it should go away. One more, case 4. Let me remember. Oh, this is a great one. Very osteopathic one. This is the case of a 23-year-old female athlete presents to me with right-sided intermittent foot drop. Was a soccer player, noted a collision while going for a tackle, a standing tackle. Somebody basically shinned her on her lateral lower leg, lower knee. And ever since then, she's had a lot of pain in the lateral knee, and she noticed herself limping more and more. And now she notices that when she goes to kick, especially repetitively, she has more pain and she has like weakness in dorsiflexion. Her kicks have been getting more and more sloppy, and it's kind of progressing over the past 3 months. So she wanted to go see a physician for it. She saw me. I took a look at her. For physical exam, full range of motion, active, passive, painless. Neuro exam was pretty normal. She had everything was negative as far as ligamentous instability, no provocative test, patellar grind, no fluid wave. But when it came to the fibular head, she had some positive symptoms from Tinel test over the posterior aspect of the fibular head, where she got some tingling down the lateral aspect of her lower leg. And that made me think, wait a second, I think there's something going on here. So I diagnosed her with not an L5 radiculopathy, but instead a more localized nerve entrapment of the common perineal nerve, especially affecting the deep perineal nerve around the fibular head due to somatic dysfunction. So I treated her, that fibular head, which was pretty posterior, and she had some improvement of her symptoms after a single week. So I treated her again. She had improvement symptoms after another week. And I think after 4 treatments over 2 months, she did pretty well. However, she still complained that after prolonged activity, she would continue to get this foot drop. So I scanned her before, and I saw that her perineal nerve was, as it comes around the fibular head, looked okay. But once it split and was going through the fibular tunnel makes up the peroneus longus or fibularis longus muscle, and a little bit of aponeurosis between that and the lateral gastroc. So sometimes it splits into superficial and deep before this perineal tunnel. Hers did. And actually, it was more deep fibular nerve that was more entrapped here. So here's the perineal nerve kind of outlined. This is common perineal nerve. So what I ended up doing was I did a hydrodissection. Hydrodissection is a procedure that you can do for nerves, hydro meaning water, dissection meaning to separate, where you go in with fluid, whether you're using saline, lidocaine, bupivacaine, dextrose, or some combination thereof. You go in with a needle and you basically insert fluid in all planes until you get what's called a donut sign, basically meaning you have fluid all around the nerve. You're basically separating all of this tissue off the nerve to let it breathe a little bit better, for example. It's kind of to decrease that compression around this fibular tunnel. And after that procedure, and of course treating her with OMT after that procedure, she had full resolution of symptoms, and I saw her 6-month follow-up. She had no more problems. So that was a really good osteopathic case, a really good ultrasound case, and I totally, this picture is not the exact picture of hers. Since she was relatively recently, I haven't pulled it off the ultrasound, but this is close enough for what it looks like over here. Next time when I do this presentation again, I'll pull off the actual images, but this is pretty close. Just so you guys know. So you can make a big difference with ultrasound for people. You can make a big difference with OMT for people. And if you have the combination of both, you have seeing, hearing, and feeling hands, and you just become that much more versatile, that much more useful as a physician, and that much better a diagnostician, really, especially in the field of sports or the field of pain or the field of OMM, neuromusculoskeletal medicine in general. It's just such a useful tool. It's so practical in office use. It's really, the world is yours once you guys learn this stuff, and I encourage you to do so. And I also encourage you not to be overwhelmed by how intimidating the steep learning curve of ultrasound. We all start somewhere. If you guys are getting some exposure to this as medical students, you're ahead of me. And you can certainly get to this point with a lot of dedication and some good mentorship. So that's the last case. I'm actually going to stop our presentation there. And I just want to say thank you guys for showing up. Really enjoyed presenting to you. If you have any questions, feel free to email me. I'll put my email in the chat, or Danielle will. My first name plus gi@pcom.edu. And yeah, feel free to reach out if you have any questions. And